I want to point out at the beginning, this was work done in cooperation with the University of Ulm, with Tobias Freitag and other colleagues in the biomechanical lab in Ulm, so that's important. This is a German slide, but we can see the age distribution quite soon in 2020, and we do see it in 2040 in Germany. So we can expect a lot of elderly people in Germany and also in other parts of Europe. So we actually have to have good strategies in the treatment of bone with low quality, with osteoporosis. This is one of those examples, an elderly patient coming to the outpatient department, and as you can see, there was one colleague in our department already having implanted a short stem on the left side, and some of you might probably think, oh, is that the right treatment? However, this patient was pretty satisfied, and he came back and he wanted the same treatment again. So so this is the planning. However, you might not have a good feeling. I won't have a good feeling also. So the alternative is a cemented stem, and maybe this is a safer solution. We believe there's certain advantages in short stem total hip arthroplasty. So we have seen this already today. We can use minimally invasive techniques. We have soft tissue sparing techniques. We can maybe achieve a bone preservation. We have seen less intraoperative fractures and less blood loss, and also a reduced length of operation. So these are all arguments maybe exactly for elderly people. They might profit of this especially. So what we thought of, we had an idea to transfer the cementless optimys into a polished cemented version, and thanks to Mathys company, they produced a polished prototype which we could test biomechanically. So we had 3 steps planned. The first one was about the cementing technique. So there's 2 different types of cementing techniques. The most common one is to achieve a consistent cement mantle of at least 2 millimeters around the implant. However, there's a couple of implants who have a different philosophy. For example, this Kerbul stem, which is, as Professor Scherling already told us, a canal filling stem. This doesn't need to have a consistent cement mantle of 2 millimeters. There will be gaps in between, and this is canal filling. But however, this stem works for 20 years. It has really very good results. So also, this is the one we prefer, the cemented stem we prefer in our clinic, and we can also see there's no consistent cement mantle around this implant, at least not of 2 millimeters. So maybe the thin cement mantle around the implant will work. So we have 2 techniques, the undersized technique and the line-to-line or press fit technique, and we tested if there's any difference for the cemented optimys. So we compared the standard, the undersized technique versus the press fit or the same sized line-to-line technique. We used, in all cases, we used the 3rd generation cementation technique. So the method is quite similar to the one Tobias Freitag just presented. There's 6 pairs of human femurs. We try to have osteoporotic or at least osteopenic femurs, as you will see in a second. And we install 2 transducers to record the reversible micromotions and the irreversible migration. These are our specimens. These are all old ladies. between 69 and 93 years. And as you can see, the T-score is quite low. It's not all osteoporotic, but this was the most osteoporotic we could get. So what did we measure? We measured the micromotion, we measured the migration. The micromotion is reversible. It's just with every load cycle, there's a certain movement in the stem, but it's reversible, and the migration is over time the movement from one point to another, which is irreversible. Oh, I'm sorry. I think I have to go back now. So you can see how this looks like. So it's quite some load. The maximum load is 1,600 Newton. So this is how it looks. One stem didn't survive the whole testing of 100,000 cycles. So this fracture occurred after 25,000 cycles in the press-fit group. So these are the results of the comparison of the press-fit and the standard group. And we have, in terms of micromotion, a tendency of a little more micromotion in the standard technique compared to the press-fit technique. However, it's not significant, so it's almost the same. What about migration? As you can see, regarding the p-values, it's almost the same. There's no significant difference in these two techniques regarding migration. So we also cut our femurs on 4 predefined levels, and we measured the cement mantle thickness on 4 predefined locations. And surprisingly, we found that there's not really a thick cement mantle in the undersized group compared to the press-fit group. Because the higher pressure we apply in the press-fit group will lead to more cement coming into the cancellous bone. So actually there's, on the anterior side, there's in the standard group, we have even less cement than in the press-fit group. That's because of higher pressure in the press-fit group, so that's pretty astonishing. This is not really working. Okay, and we also did the fracture. We tested the fracture load, as you can see, which was the maximum load applied until the fracture occurred. And these are the types of fractures we could produce. It's in all of those cases, it were Vancouver type B fractures, and you will see that the fracture load is actually not different in those groups. We have 3,895 Newton in the standard group and almost the same in the press-fit group. So no difference really in all cases. We had a Vancouver type B fracture. So from this first step, we can tell there's a slight tendency of higher micromotion in the standard technique, but it's not significant. We have equal implant migration in those two groups. There was no significant difference in cement mantle thickness due to greater penetration into the cancellous bone. And we have a tendency of less fracture load in the press-fit technique, however, also not significant. So we actually followed the press-fit technique further because this suits more the philosophy of this short stem. This is already published. You can read it if you're interested in. We started with the second step, and this was a comparison of the cemented optimys versus well-known cementous chorile stem. It's the twinsis. It's also polished, so this is well established. And we compared these two stems. Again, we had 6 nice ladies with osteoporotic bones. And the results for the micromotion, we can tell there's no significant difference. There's even a tendency of less micromotion in the optimys stem. Same for rotation, no difference. What about migration? There's no difference, no statistical difference. However, also a less tendency in the optimys stem to migrate. The same with rotation. So what about the fracture load in this step? It's again equal, it's the same. However, we have different fracture patterns. For the optimys stem, we have Vancouver type B fractures. For the twins stem, we do have Vancouver type C fractures. So that's a real difference. And maybe this has consequence for surgery also, so we have to keep that in mind. So in conclusion, no significant differences between optimys and twins regarding micromotion, migration, and fracture load, but the fracture type in the optimys stem was B3, and in the twins it was C. So this is quite encouraging to maybe further pursue this cemented short stem. What about step 3? This is, we have seen results of a finite element analysis just now, so we right in the moment are doing exactly this for the cemented stem, and also after this we will try to abduct a clinical observational study, but this is still a way to go. So you can see pictures from Brussels with Professor Scherling and Professor Feil. We implanted some cemented optimys stems to do the FE analysis. So in future, maybe when those patients come to us in the outpatient department, we don't have to decide if we do the short stem or we do cemented. Maybe we can just plan the short stem and then decide intraoperatively if it will be uncemented or cemented. But this is the future. It might work. We don't really know right now, but it might work. Thank you very much.